Imagine this, you're 51 years old, you run a company, you sit opposite your private GP at a Harley Street practice, and you are halfway through your annual medical. Your bloods are normal. Your ECG is normal. Your blood pressure is on target. Your cholesterol is, in your doctor's words, fine. You are told in those exact words that you have the body of a man 10 years younger. 6 months later, you're in the back of an ambulance with chest pain. This is not a hypothetical. I have sat across from too many men in exactly this situation. And the lesson is always the same. Everything their doctor measured was within range. Everything that actually mattered, their doctor never measured. In the next 10 minutes, I am going to walk you through the 6 tests your annual medical's almost certainly not running, why each one matters more than what is on your current report, and how to know whether your own annual is giving you a real picture or a comforting illusion. Quick word before we go further. If you are watching this and you are a man in your 40s, 50s or early 60s running a demanding career, subscribe to this channel. Every video here is built specifically for you, and in the description below you will find a free executive longevity scorecard. 8 minutes free, and you get a personalized PDF report on the 6 pillars I work on with my Harley Street clients. Link is in the description. Now back to it. Here is the framework I want you to hold in your head for the rest of this video. I call it the annual medical illusion. Standard medical care is built around a binary question. Are you ill or are you not? The thresholds your GP uses on every test on your annual are calibrated to detect disease that has already clinically arrived. They are not calibrated to detect aging in motion. And the gap between not ill yet and aging well is roughly 15 years wide. 15 years, that is the runway you have in your 40s and early 50s to change the trajectory of your 60s and 70s. And that 15-year window is exactly where precision longevity medicine lives. It is the ground that standard medicine is not designed to cover. The 6 tests I am about to take you through are the bridge across that 15-year gap. Each one measures a process, not an endpoint. The processes are what age you. The endpoints are simply what arrive when the process has been running too long, unmeasured. Here is the framework I want you to hold in your head for the rest of this video. I call it the annual medical illusion. Standard medical care is built around a binary question. Are you ill or are you not? The thresholds your GP uses on every test on your annual are calibrated to detect disease that has already clinically arrived. They are not calibrated to detect aging emotion. And the gap between not ill yet and aging well is roughly 15 years wide. 15 years. That is the runway you have in your 40s and early 50s to change the trajectory of your 60s and 70s. And that 15-year window is exactly where precision longevity medicine lives. It is the ground that standard medicine is not designed to cover. The 6 tests I am about to take you through are the bridge across that 15-year gap. Each one measures a process, not an endpoint. The processes are what age you. The endpoints are simply what arrive when the process has been running too long, unmeasured. Let me tell you about a patient. The details are anonymized, but the pattern is one I see every week. Late 40s, founder, had just sold his company, came in for what he called a longevity MOT because his wife had asked him to. He brought his private medical from 3 months earlier. Every standard panel was clear. He had been told, and I quote, that he was in excellent health for his age. We ran the 6 tests I am about to describe in this video. 5 of the 6 came back significantly out of range. His biological age on epigenetic testing came back 9 years older than his chronological age. He was 48 on his passport. He was 57 on his cells. He had no idea, and importantly, neither did his GP. Not because his GP was negligent, but because his GP was never asked to look. And here is the lesson I want you to take from that. The tests your doctor runs answer the question, am I sick? The tests in this video answer the question, am I aging well? Those are not the same question. They are not even close. Test number 1, biological age testing, specifically an epigenetic clock, what it measures, the methylation patterns on your DNA that reflect cumulative biological wear. Why it matters. It is the only test in modern medicine that gives you a single defensible number for how fast you are actually aging relative to your chronological age. Standard medicine has nothing equivalent. Your annual medical does not include this. At Genexera, we partner with Lola Health, who run the TruAd Complete and Stride BioAge assays, both of which give a clinically meaningful biological age read. Test number 2, fasting insulin. Not just fasting glucose, what it measures, how hard your pancreas is having to work to keep your blood glucose in the normal range, why it matters. Insulin starts rising 5 to 10 years before glucose ever does. By the time your fasting glucose is abnormal on a standard panel, the metabolic damage has been compounding silently for the best part of a decade. If you have watched my recent video on the lean executive who was metabolically obese, you already know where this leads. A normal fasting glucose with a high fasting insulin is the single most common pattern I see in lean, high-performing men in their 50s, and it is invisible to a standard medical. 2 tests in. One measures the speedometer of your aging. The other measures the metabolic engine that is driving it. Neither is on your annual. Test number 3. ApoB, apolipoprotein B. What it measures. The actual count of ApoB circulating in your blood. The ones that drive plaque formation in your arteries. Why it matters. ApoB is now considered by every serious cardiovascular preventive cardiologist I know the single most accurate marker of cardiovascular risk available. And almost no UK private medical runs it. Most still report total cholesterol, LDL and HDL and call it a day. Total cholesterol in 2026 is a deeply blunt instrument. ApoB is the sharper one. It belongs on every annual. Pronunciation note, ApoB =, pronounced AYPOB, apolipoprotein = AP or lipoprotein. Test number 4, lipoprotein, little a. What it measures. A genetically determined cardiovascular risk factor. It is largely fixed. It does not move much with diet, exercise or lifestyle. Why it matters. Roughly 1 in 5 adults has an elevated lipoprotein, little a. If yours is high, your cardiovascular risk is significantly above what your other numbers would suggest, and you and your doctor need to know that. Here is the part that frustrates me. It is a once-in-a-lifetime test. You only ever need to do it once, and almost no one in this country has had it. Pronunciation note, lipoprotein =, apolipoprotein. Read lipoprotein little a rather than LPA. It scans better. Test number 5, high sensitivity CRP, hs-CRP. What it measures, low-grade systemic inflammation. The kind that is too quiet for standard CRP to detect. Why it matters. Chronic low-grade inflammation is the common biological pathway for cardiovascular disease, neurodegeneration, and metabolic dysfunction. 3 of the big 4 aging diseases. Standard CRP is too blunt. It will only flag inflammation when it is already loud. hs-CRP catches it while it is still a whisper. 3 tests in this scene. 3 of the most important cardiovascular and inflammatory markers in modern medicine, none of them routinely on your annual.
Test number 6, VO2 max. Measured, not estimated. What it measures, your cardiorespiratory fitness, specifically the maximum volume of oxygen your body can use during intense exercise. Why it matters. Across every major mortality data set of the last 20 years, VO2 max is the single strongest predictor of all-cause mortality, stronger than blood pressure, stronger than cholesterol, stronger than smoking status in some studies. And it is missing from every annual medical I have ever reviewed in clinic. Estimated VO2 max from a wearable is not the same thing. A measured VO2 max on a treadmill or bike with a mask. Now look at the pattern across all 6 tests. Biological age, fasting insulin, ApoB, lipoprotein little a, hs-CRP, VO2 max. Every single one of them measured trajectory. Not status, not are you ill, but where are you headed? That is the difference between a medical that finds disease and a medical that prevents it. That is the precision longevity layer. And it is the layer most men in this audience have never had.
So how do you actually get this done? 3 options, in increasing order of completeness. Option A, ask your existing GP to add these specific tests to your next annual. Name them precisely. ApoB, lipoprotein, little a, fasting insulin, hs-CRP. Many private GPs will run them if asked. The caveat is that most will tell you the result is within range because they are reading against population thresholds, not optimization thresholds. You will get the data, but not the interpretation. Option B, use a direct-to-consumer biological age test, for the methylation piece. Lola Health, who I work with, run True Age Complete and Stride Bioage. You can order these directly. You then bring the results and any private bloods you have run separately to a clinician who can interpret them in a longevity context. Cheaper, partial picture, better than nothing by a long way. Option C, a precision longevity program that runs the full panel, interprets every result against your 6 pillars and builds a 90-day intervention plan around what is found. This is what my precision longevity blueprint is built around. It is not the right fit for everyone. It is the right fit for men who want the full picture and the clinical interpretation in one place. Here is why I have called this video what I have called it, why it matters by 50. Every one of these 6 tests, abnormal in your 40s, predicts an event or a decline in your 60s. Every one of them, caught in your 40s, is modifiable. That is the symmetry that makes this whole field work. But the maths only works if you start in the marginal decade, the decade between 40 and 55, because the interventions take 90 days to show meaningful biochemical change, 12 months to show structural change, and 5 years to show outcome change. If you start at 45, you have time. If you start at 60, you are running a different race entirely. That is the cost of the annual medical illusion. It is not just that the standard tests miss what is happening. It is that by the time the standard tests catch up, the window for the cleanest, easiest, most durable interventions has already started to close. This is the entire reason precision longevity medicine exists as a discipline, to close that 15-year gap while there is still runway. 2 things, then I will let you get on with your day. First, if you have not yet taken the Executive Longevity Scorecard, that is your first step. 8 minutes, free. You get a personalized PDF report telling you which of the 6 pillars, including medical optimization, need your attention first. The link is in the description and pinned in the first comment. Second, if you are already at the point where you know you need to run the full panel and have it interpreted clinically, the Precision Longevity Blueprint is the 90-day one-to-one program I run from Harley Street. The application link is also in the description. There is a short conversation first to make sure it is the right fit. Whatever you decide, do not mistake a clean annual medical for a clean longevity picture. They are not the same thing. I will see you in the next one.